Thank you very much for the kind invitation for this wonderful venue and to have the opportunity to talk about medical treatment of male LUTs. Mono or combined therapy, these are my disclosures, my potential conflicts of interests. And of course, this is relevant for all of us in our clinical practice because if we believe on the EpiLUT study, above the age of 40 years of age, 70% of men will have symptoms. Might not be very bothersome, but they will have symptoms, either storage, either voiding, post-micturition, or a combination of these three types of symptoms. And of course, this was already shown, and there are many causes for male LUTs, and so the treatment might be sometimes difficult to decide, but the most important etiologies for male LUTs are, of course, benign prostatic obstruction caused by BPH, overactive bladder, idiopathic overactive bladder, nocturnal polyuria, as already mentioned by Salvador Hernandez, and the Truser underactivity. But I am not going to address more the Truser underactivity because unfortunately we still don't have therapy, medical therapy for the Truser underactivity. So if we start by BPH and benign prostatic enlargement, we know that this is something that occurs virtually in a large BPH in virtually all men and causes an enlargement of the prostate in a large proportion of men, particularly elderly men. And sometimes it is useful to revisit old studies. And this is a study by Matthias Ulk. He performed the pressure flow studies in almost 1,500 patients. And the observations are curious. First, that 80% of the patients had some degree of obstruction, although mild in the majority, but they had some degree of obstruction. And the more obstructed in the Schaeffer's classes of obstruction were those with larger prostate glands. The second thing was that the Truser overactivity was related with prostate volume, and 60% or more of the men that he studied had the Truser overactivity, which can explain why patients with BPH and benign prostatic enlargement have a combination of voiding and storage symptoms. The other thing that is important is to remember that the prevalence of OAB is exactly the same in men and women, probably slightly higher in elderly men. And when we talk about elderly men, the number is not 11%, that is an average number. The prevalence might be 30% or higher. And in addition, nocturia is the most common symptom among the lower urinary tract symptoms in men and women. In this study, from the SIA study, the proportion of men above the age of 60 that had nocturia was more than 80%, and half of them had severe nocturia. But they also had something more. They had nocturnal polyuria, which 20% had nocturnal polyuria, which means that they need specific treatment for that really is able to address nocturnal polyuria. So said that, what do we have for the treatment of male LUTs? We have all these drugs that can be used in monotherapy or in combination. Alpha blockers, 5-RIs, antimuscarinics, beta-3 agonists, PD-5 inhibitors, and desmopressin. They can be used alone or in combination. This was the first combination that was really investigated, but all the other combinations have been investigated. Some of them more, some of them less intensively, but all these combinations are possible. Well, so starting by alpha blockers, there is really nothing new about alpha blockers. What is written in EU guidelines is that they improve voiding and storage LUTs. The IPSS is expected to decrease by 30 to 40%. A small increase in terms of average in flow, about 2 to 2.5 mLs per second. The effect is fast, and it is why it is one of the first drugs that is used throughout the world, can be used across all age groups. And if you ask me what is the best one, in terms of efficacy, all of them are very similar. In terms of adverse events, there are some differences related with the alpha-1A specificity. So those that are less specific for alpha-1A receptors might cause orthostatic hypotension, which is a problem or might be a problem in elderly patients, while they will cause dry ejaculation, which of course is a problem in younger patients. So that is alpha blockers. Because many patients have bladder outlet obstruction, it was interesting to see this study carried out by Fernando Fusco in Italy, showing that all the alpha blockers are able to reduce slightly bladder outlet obstruction measured by the bladder outlet obstruction index. It's not a big change, but it slightly improves obstruction. Do they work well in all volumes? Apparently, yes, in the short term, but eventually not in the long term. And that is something that we might need to discuss with our patients. On the left is the old study from Dr. Boyle with terrazosine that we don't use anymore, but showing that, anyway, the large prostate glands had lower responses in terms of symptomatic improvement than the smaller prostates. And on the right side, the data from the COMBAT study for large prostates. And as you can see, the blue line that is for tamsulosin alone, the effect is fast at 3 months, but then gradually along 2 years, there is a loss of effect. Thus, this goes on throughout the years, after 3-4 years of continuous treatment, we don't know exactly. 2 years ago, we were surprised by a study coming from US, the analysis of the US Medicare data showing that patients under tamsulosin and alpha blockers in general were at risk of developing dementia. That caused a big debate and a lot of letters to the editor criticizing the way the study was conducted. And I think it is important that in Barcelona, in EAU this year, the Korean brought their experience from the National Health Insurance database, showing that in their large entire population, they could not see any evidence for dementia in patients under chronic treatment with alpha blockers or tamsulosin in particular. So that is quite reassuring, and of course the data from US needs more investigation. About 5-RIs, the indications are those that we all know. They are excellent for moderate to severe LUTs. That is their indication in patients that are at risk of progression and that have large prostate glands. And it is important to measure the prostate volume because they are not effective in prostates below 40 mLs. The increase in flow and the improvement of IPSS is lower than with alpha blockers, but on the other hand, they might reduce the risk of acute urinary retention and surgery. And both drugs, dutasteride and finasteride, are equally effective. What is the new problem with these 5-RIs is that we all know that they cause erectile dysfunction. And in the first year, we can expect 10% of the patients having erectile dysfunction. The problem is that in 1/3 of those patients, erectile dysfunction can be permanent. And so there is now the permanent erectile dysfunction that is something that we have to discuss with patients that will be exposed to long periods of time to these drugs, particularly if they are young. So something that we have to discuss with the patients now. About the use of PD-5 inhibitors alone for the treatment of male LUTs, they are effective for voiding and storage LUTs, but if you look to the meta-analysis, the improvement is 2.8 in the IPSS, which is not a big improvement, and eventually it is in the limit that can be recognized by patients. They don't increase Qmax, so the mechanism of action might be completely different, and of course they improve erectile function, and that is why in the EAU guidelines these drugs are recommended, particularly for young patients. Nocturnal polyuria is present in 20 or eventually in more than 20% of the patients. And it will not be treated if the patient has nocturia due to nocturnal polyuria. The patient will not be improved with alpha blockers, 5-RIs, or PD-5 inhibitors. They will require something different. And in terms of therapy, I'm not saying that the first step is therapy. There are conservative treatments for nocturnal polyuria, but clearly, if we want to improve these patients, we might need desmopressin, but there is the other side of the coin. We need to check on a regular intervals the plasma sodium levels, and the first check should be at 3 to 4 days after the introduction of desmopressin. And what about combinations? Well, this is the first combination, the old MTOPs, and it is probably the basis for this recommendation in EAU guidelines to offer the combination for patients that have a high risk of progression, large prostates, more than 40 mL, and moderate to severe LUTs. And in fact, combination reduces progression and the risk of acute urinary retention and the risk of surgery. Of course, we have to remember that they now have the risk of persistent erectile dysfunction, something that we have to discuss, particularly because there are fixed combinations. Of course, there are many patients that have storage LUTs that persist after alpha blocker medication or 5-RI medication. And these persistent storage LUTs, so might be OAB if you want, might need to be treated with antimuscarinics that might be used in an add-on approach. So if alpha blocker is not okay, add on an antimuscarinic or a fixed combination, because there are fixed combinations. The indication is clear, is strong for patients that have persistent storage LUTs after monotherapy, but antimuscarinics require a regular check of post-void residual and are not recommended in patients with post-void residuals above 150, and the reason is simple, because all those patients were excluded from the trials in which the antimuscarinic drugs were investigated. But now we have the possibility of using the beta-3 agonist, mirabegron, and what I'm showing here is the design of the PLUS study that was presented in last AUA in Chicago. So the design was simple: 4 weeks of tamsulosin. If the patients were not satisfied, they were randomized to tamsulosin plus placebo or tamsulosin 0.4 plus mirabegron 50. And the endpoint was the frequency, the number of micturitions per 24 hours, and the study was positive. In the mirabegron arm, there was a decrease of 2 micturitions per day that was superior to that was observed in the placebo arm. In addition, and that is something that might be relevant for our clinical practice, no changes were observed in post-void residuals, and no changes were observed in Qmax. So it means that probably this combination might be safer than the combination with antimuscarinic drugs for general use. Finally, I would like to show to you this study coming from McGill. And they analyze the type of patients that are coming to surgery in 3 periods, until 2004, from 2004 to 2009, and from 2009 until 2014. And with the introduction of medical treatment, what they observed is that the age of the patients that are now treated, the patients are older, more than 10 years before. The prostate glands changed from 74 mL to 87 mL, a huge increase in average. The flow was worse, so it seems that although using medical treatment, we are pushing the limits of medical treatment probably too much. And at the same time, clearly the patients were more under medical treatment, more patients under medical treatment, and there was a slight change along the years, and nowadays the preferred treatment is probably the combination or the alpha blockers alone. Alpha blockers alone or the combination with 5-RIs. So something that we have to take into consideration, are we pushing medical treatment to limits, and are we having now worse patients to be treated surgically when medical treatment is no longer effective? I think this is something for the discussion. What I want to finish now is with the conclusions. The males, as they get old, will report a combination of voiding and storage LUTs that can be treated in monotherapy or with various combinations. Patients with persistent storage LUTs after an initial period of monotherapy, they might be treated with antimuscarinic drugs or with mirabegron. Nocturia by itself, which is the most common symptom in males, requires a specific investigation, and remember that many patients will have nocturnal polyuria, which requires a specific treatment. The risk of dementia associated with alpha blockers is not demonstrated until now. 5-RIs may cause persistent erectile dysfunction, so we need to inform younger patients, and eventually long-term medical therapy for male LUTs may change the characteristics of our patients at surgery. Thank you very much for your attention.